Okay, we'll get started. So hi, everyone, and welcome to today's webinar, providing around-the-clock support services in Hamilton County, Ohio. My name is Melanie Gibney, and on behalf of Hamilton County Public Health's harm reduction team, I'd like to thank you all for joining us today. So during this webinar, all participants will be on listen-only mode. And at any time during the webinar, if you have any questions, please feel free to enter those into the chat box and we'll get to those at the very end. If we don't have time for all the questions today, we will answer them via email as well afterwards. A recording of the webinar and the slides will also be available afterwards as well. If you experience any technical difficulties, please also type that into the chat box and we will assist you as needed. So here is the agenda for today's webinar. So we'll begin with a quick welcome and overview, and then you'll hear from Philip Graham from Hamilton County Public Health, and then you'll hear from Tiffany Surratt and Brad McMonagle from the Talbert House of Cincinnati, and finally from Lisa Mertz from the Addiction Services Council. We'll also have a brief Q&A and discussion at the end. So by the end of today's webinar, we hope that you all will learn about unique programs in Hamilton County Public Health here in Ohio that provide care when people need it outside of non-traditional hours. You'll also hear more about Talbert House's alternative transport program, and you'll learn about challenges and successes of the Afterhours Individualized Mobile Engagement Program, or the AIME program. So we will do a few introductions now. So from Hamilton County Public Health, you'll hear from Philip Graham, who received his Bachelor of Science in Nursing from the University of Cincinnati College of Nursing. He worked in the emergency department at UC's Medical Center and at Mercy Anderson Hospital before moving to HCPH in the Disease Prevention Clinic. And now he is the Senior Health Counselor and my supervisor in the Harm Reduction Division at Hamilton County Public Health. He's also earning his master's degree from Ohio University. Then you'll hear from Tiffany Surratt, who's the Associate Director at Talbert House, where Tiffany oversees 20-bed withdrawal management short-term residential program, or she manages the program, including post-overdose withdrawal management and alcohol withdrawal management. Before becoming the Associate Director at the Engagement Center, Tiffany began her career with Talbert House in 2003 as a case manager, and then a clinical operations supervisor with the mental health court program and misdemeanor day reporting program coordinating treatment for dual diagnosed clients. Then Brad McMonagle, the chief clinical officer at the Talbert House. He received his Bachelor of Science in Psychology from University of Cincinnati and his MA in counseling from Cincinnati Christian University. And he's been involved in the non-for-profit community behavioral health industry for about over 25 years. He's active at the local and state levels around significant changes in healthcare, both in legislation and service provisions. Brad is currently leading the transition of Talbert House into a fully integrated person-centered medical home. And finally, you'll hear from Lisa Mertz, who is the president and CEO of Addiction Services Council. She earned her bachelor's degree in criminal justice and in nursing from the University of Cincinnati and is currently attending law school at Northern Kentucky University. Prior to accepting her role at the Addiction Services Council, she served as the administrator for a home health agency, and she's very passionate about serving those suffering with substance use disorders and focuses on providing immediate access to treatment for individuals in crisis. So with that, I know it was speedy but efficient. I will now turn it over to Philip Graham to talk more about Hamilton County Public Health.
Hello, everyone. I'm going to be fairly brief. Our main speakers are the people following me. I'm just here to give a quick overview on kind of some of the services, since our topic is around that kind of 24-hour access and support. The few things that we do have through Hamilton County Public Health, and we have shared these at previous webinars, so this may be a refresher for some of you. But we have probably the big one is our On the Front Lines Facebook chat, which is a service that was actually started outside of the health department and then brought under kind of our support umbrella with one of our staff members, Hannah Schilling, joined on. And that has over 200 members. I think the Facebook chat limit is 250, and we pretty consistently get up to that, reaching that 250 limit, and have to go through and kind of ask people who aren't as active to move on, so we can have room for more people that are doing the great work in the field. And this group is a whole host of different people, from individuals working as peer supporters, people who work for treatment agencies, just people working in the addiction and recovery support field in general. And it's all kinds of different questions, and they come up, they really do come up 24/7. And being this group of 200, 250 people, people know they can come on there and get answers to their questions. Everything from, is there open beds at certain facilities, to very unique situations, around placement barriers, insurance barriers, and other things like that. So it's a pretty great resource. It is fairly focused around Hamilton County, but we do have a lot of people from the Northern Kentucky area, as well as up into Montgomery County and Dayton, and a lot of treatment providers from the region in general get on there too, who maybe provide transportation to their facilities that aren't in Hamilton County. So it's a great resource. And that kind of led us into the Recovery Connections Forum. So one of the downsides of the Facebook chat is, with that many people, it does move quick. So say a week ago, someone asked the question about looking for a special situation for a treatment facility that has room for maybe a couple, right? And if I was trying to find that same information, it's not really a searchable database. So it creates a barrier for finding that information again. In addition, we were ending up with a lot of repeat questions. So we started the Recovery Connections Forum, which you can see the link there. It's recoveryconnections.hcph.org. It is an online forum with a searchable database with hundreds of posts. It started off with, again, Hannah Schilling, our my staff member here at HCPH, who basically, she says, downloaded her brain into this forum, and it is a ton of resources on what's available in Hamilton County, everything from food and housing assistance to specific information about treatment facilities, recovery housing. And we often take information from that on the Frontlines chat and put it right into a post on the forum so that it can be referenced again and again. So it's really great, two really great tools people can access 24/7, and it's not necessarily just, it's living, both of them, right? They're constantly updating information and new posts and new information. That's all I had.
Great. Thanks so much, Philip. And like he said, if you have any questions about this, you can reach out to us or Hannah Schilling, who is who coordinates and leads the Facebook group and also the Recovery Connections. So it's a really great resource, like you mentioned. And with that, we will also now turn it over to Tiffany and Brad from the Talbert House.
Good afternoon, Brad McMonigal. Thanks, Melanie, and thanks, Philip. And thanks everyone for joining us today. Hopefully lots of good information we'll be able to share. I'm just going to do a quick background on the Engagement Center and turn it over to Tiffany, as she's much more intimately involved with the program. Just brief history, Talbert House about 6 years ago began to distribute and train on the use of naloxone. And so we've been a leader in the area on distribution of the naloxone kits, really regionally here in Southwest Ohio. But during that time, there was lots of concern and consideration around what do we do with individuals post-overdose? How do we treat them? How do we get them acute and immediate care? And we had the opportunity to visit Maryhaven up in Columbus, where we learned quite a bit about their residential program. And through local board dollars, obviously state opioid response dollars, we were able to partner a little bit with UC on information and put together the framework for the Engagement Center. And we certainly, over the years, it's been about 3.5 years since we opened. We've learned a lot, we've grown, we've made some adjustments and changes, but where the Engagement Center is today it's an outstanding program for our community. And we are certainly happy to be able to present what it is that we're doing and answer questions that you may have from the community. We've learned a lot. Some of the ideas we had going in have certainly changed and many of that's just built on just the individuals that we're serving has helped kind of guide us along the way. So very happy to turn it over to Tiffany. She's a outstanding leader at our engagement center, and she does just a great job of keeping all the pieces together. So Tiffany, it's all yours.
Thank you, Brad. Appreciate it. So thank you again for the invitation to speak about Talbert House Engagement Center and how we are providing those round-the-clock services to those most in need. I wanted to start off with our Talbert House mission, which is empowering children, adults, and families to live healthy, safe, and productive lives. Talbert House's vision is a caring community that believes in recovery, second chances, and personal growth. Our values are advocacy, collaboration, holistic, inclusion, integration, integrity, quality, and safety. So as mentioned before, the Engagement Center is a post-overdose withdrawal management treatment program. We will take those individuals who have just overdosed, which is an important piece of this aspect. We are a short-term residential co-ed facility. We have a 20-bed capacity. Treatment for individuals needing withdrawal management from opiates, cocaine, methamphetamines, and now we are also proud to say that we are able to help those withdrawing from alcohol also. Our daily cognitive behavioral therapy groups, and we utilize the UC CBI curriculum. What ties into mostly our round-the-clock care is our partnership with the Emergency Triage, Treat, and Transport program, also known as ET3. So Chief Carsdale Winston, who is the district chief of the EMS operations with the Cincinnati Fire Department, in conjunction with Dr. K. Maria Tahemba, the director of addiction services at Talbert House, and the Hamilton County Addiction Response Coalition, identified a need to provide additional services to those individuals that had recently overdosed with treatment outside of emergency rooms. So partnership with the Engagement Center and the Cincinnati Fire Department EMS began on January 1st of this year. The partnership with the Engagement Center allows those who have with post-overdose clients to come in for treatment directly from EMS, bypassing the need for going to the emergency room. The Engagement Center provides 24-hour nursing dedicated to responding to the referral calls from the fire department and paramedics, immediate coordination with the Engagement Center to receive the client and begin that intake process. And the fire department EMS can transport individuals to the Engagement Center 24 hours a day for treatment. We have a nurse set up that will take those calls at any point in time, do a short referral call with those individuals, the EMS, to make sure that we can know what is going on with the client and readily accept them and start their treatment process. So why the need for non-traditional hours? Opiate overdoses have continued to unfortunately rise in Hamilton County. Over the past year, EMS has responded to over 967 opiate overdoses, which amounts to about 81 a month. After an overdose, those individuals revived by Narcan do not necessarily need or want to go to the emergency room. So this partnership allows for individuals to be transported to the Engagement Center and begin treatment right away, as opposed to missing those most in need who may go to the emergency room and just be discharged afterwards without a connection to treatment. We have eligibility for the Engagement Center. We will take adults, male and female, so we are co-ed, 18 years of age and older. They would need to be Hamilton County residents with or without medical coverage, or Ohio residents outside of Hamilton County with medical coverage. Individuals in need of withdrawal management. For those individuals that come in without insurance, we will do everything that we can with regard to getting them insurance. We do have some exclusionary criteria. We try to minimize that as much as possible so that we can help as many as we can. However, those exclusions do come under short active psychosis or suicidal homicidal ideation, untreated seizure disorders, untreated high blood pressure, or untreated COPD or asthma, PICC lines, intravenous access, or open wounds that require packing, tuberculosis, active lice or scabies infections, staph infections, hepatitis A, or insulin-dependent diabetes. If we do have an individual that has had some issues with psychosis or suicidal homicidal ideation, if we can obtain a site clearance prior to their entrance into the engagement center, we will take those individuals also. We will just need that site clearance prior to. The clients served at the engagement center over the past year, we've serviced over 600 clients within the past year. Our average length of stay for all clients is 12 days. 25% of our population served are people of color. 81% of the clients we have served were Hamilton County residents. 44% of those clients were homeless. 75% of our clients have mental health and substance use disorders. And 73% of those served have an opiate use disorder. The services we're able to offer at the engagement center are a medical and biopsychosocial assessment, withdrawal management, medicated assisted treatment, MAT, with buprenorphine and Vivitrol. We offer case management, individual and group therapy, peer recovery services, 24-hour nursing care, discharge planning, and other Talbert House and external referrals for outpatient treatment, housing, mental health treatment, anything else that we can do to make sure that the client is serviced. At the engagement center, our staffing, we have 24-hour therapeutic support staff, our resident assistants who are with the clients 24 hours a day. We also provide 24-hour nursing with nurse practitioners, RNs and LPNs, clinical counselors, case managers, and peer recovery coaches. We want to make sure that we have additional interaction with the clients, even beyond their stay with even beyond their treatment with regard to the engagement center, hence our partnership with our peer recovery coaches also to help walk with them throughout the remainder of a year's time to help them stay in sobriety. Thank you for your time. Appreciate it.
Great. Thanks so much, Tiffany and Brad. And yeah, there are a few questions, but we'll get to those at the end. So thanks so much. Okay, and now we will hear from Lisa Mertz from the Addiction Services Council.
Hi, thank you, Melanie, for all of your wonderful preparation work. She's the most organized person I've ever met in my life.
Thanks.
I have control issues, but I'm not organized like that. So that's great. So thanks to Hamilton County Public Health. Thank you to Talbert House. The AIME team is particularly excited about the engagement center because of the 24-hour access that relates to our program. So with that, I will start by telling you a little bit about the Addiction Services Council. So we've been around since 1949, so more than 70 years. We were established as the Alcoholism Council, and as substance use disorders changed and evolved, so did we, and we are now the Addiction Services Council. I we'll try and be as unboring as possible and not read this to you. So I'm sure you can read the mission, vision, and slogan. But we have been dedicated to providing a variety of treatment and prevention services for adolescents, adults, and children over the years with any type of substance use disorder. The services we currently offer include assessment and referral. So we have open access walk-in hours for assessments every day, Monday through Friday. And we provide clinical triage, case management. We do outpatient, individual and group counseling, family intervention and support. We have education programs. We even have a children's camp that's going on right now. And we have been operating the Recovery Health Access Center information and referral line for years now, but so we have experience with operating a 24/7 hotline. So we expanded that to include the AIME team, which was started, it launched in February of this year. And it is my baby because I am very passionate about addiction, and I recognize that people with alcohol use disorder and other substance use disorder have a very limited window of willingness. So we really wanted to capture that. Sometimes when we say we respond quickly, it's not really that quick. So I wanted to have an immediate access of in-person response to capture that limited moment of willingness. So that's where the AIME team came from. It gets really disheartening when somebody has called your line last night and you couldn't get them in anywhere, and now they've passed away. So you always wonder what would have happened to them. So what is the AIME team? It's the After Hours Individualized Mobile Engagement Team. It's available. I know this is a nationwide thing, but it's available to medical providers within the 275 loop and emergency departments, urgent care centers, and people even living at home. So it is from 8 p.m. to 8 a.m., 365 days a year. We offer in-person support. So anybody can call our hotline and a peer supporter will answer. And if the person is willing and wants to have an in-person peer support visit, the person will go out there. Usually they're there within 30 minutes, sometimes faster. And we really just work with the individual, whether they're ready or not to get treatment. It doesn't matter. Sometimes they call 13, 14 times in a day. The telephone service is available 24/7. We were funded initially just to have overnight peer supporters. We have since been awarded a grant to allow for a daytime peer supporter to provide these services as well. So I look forward to expanding that. We've got 2 teams of 2. And they're certified peer recovery supporters. We also help them get their CDCA if they don't have that already. The teams are 1 male and 1 female that are specifically trained to respond to people in crisis. They received special training for this. And like I said, they make in-person visits to hospitals, residences, and then we actually physically take them to treatment immediately if they're willing, which is something different, and we handle all of that. So the key components of the program is that use of the 2 teams of 2, because people have special needs. Some people are not comfortable working with the male, are not comfortable working with the female. And when we're transporting people, particularly at night or responding in person, it's nice to have teams of 2 if possible. And they really have a working knowledge of the area treatment centers, community resources, Medicaid, who takes what, indigent funding. So there's really nobody we can't see, and it's really neat. And we definitely collaborate with area hospitals and treatment centers, first responders, law enforcement. So the quick response team in our area has our AIME cards for people that aren't ready when they go, but might be later. The hospitals probably call more than anyone else because it really takes the burden off of their nursing staff. to make sure that somebody gets connected to treatment. And my staff will sit there for hours if need be with an individual, helping them get where they need to go. So it's a really special program. So the steps that we took to launch the program really included gathering data to determine the need and the targets. And there was limited data available. It was kind of disheartening. Everything's so fragmented with hospitals. We have data on people that overdose and, emergency department visits, and how many people, call us for services. But with the numbers we were able to get, it was pretty clear that there was certainly a gap in access to treatment overnight and on the weekends. And then we requested community insight, from other treatment providers. What kind of calls are you getting? People in recovery, what barriers did you experience when trying to get into treatment? And we really use that information to create our program plan. The program budget was pretty clean cut, phone for individuals and support staff. And obviously mileage, which isn't going that great with the gas prices right now. And then we applied for funding. We applied at the state level through OMOS and were awarded a grant to do that. So that was really great. And we started implementing the program, which required, making policies and procedures, safety planning. I'll get into that in a little bit. And we continue with ongoing evaluation and improvement and plans for expansion of the program. So in the pre-launch planning, I already kind of mentioned that we gathered that data and insight, but when creating the program plan, we really honed in on program goals and objectives because everybody wants data today. So we really tried to solidify what particular data points we were capturing, what population we were targeting, how we were going to do that through Facebook, posts, Instagram, handing out cards, street outreach, things like that. Liability issues and planning for your insurance needs. You've got non-owned autos, patients in the car. So we had to work with the insurance provider for that. And what most important to me is ensuring my staff safety and the client safety. Very, very, very important. And we kind of went over the program budget as well. So when we went into the program implementation, the data that we collect on an ongoing basis includes the number, type, and length of phone calls, the number of in-person visits made versus the amount of phone calls, obviously demographics, drug of choice. And I will say most of our calls have been alcohol use disorder, which was surprising to me. It tells me that there may be a lack of treatment availability for people with alcohol use disorder when the focus is on opioid use disorder a lot of time, which is great that the engagement center started taking patients with alcohol use disorder. It kind of helped us out quite a bit. And we also track successful admissions to treatment. How many people did we take there and ensure that they got in? And then we try at the 30, 60, 90 day and 6 month and 1 year marks to follow up with the people to see it, how they're doing. Are you still engaged in a program? Do you self-report as not ingesting any substances? That is the most difficult data to track, particularly because the phones are disconnected after they enter treatment. But we do try, and I'm always open to feedback from people on how to improve that data. And really important to me is having a robust program where we can accomplish this day and night, 365 days a year. So I constantly explore funding sources for daytime hours, and I kind of piece it together. The sustainability is the most difficult part, but I'm working on that, what can be billable in the future as opposed to having just solely grant funding and private donations. And we actually did just get a grant for a transportation vehicle. So we'll be purchasing that most likely at sticker price the way things are going right now, so that we don't have to have staff using their own vehicles, which is particularly challenging for them to maintain their vehicles when they don't make a ton of money. I will not read the flow chart to you, but there is a flow chart if you're interested in replicating this in any way, of what we do. We obviously, when anybody calls, we do an in-person visit risk assessment, most importantly, because we want to make sure that where we're going is going to be safe for staff and clients. We don't allow them to go inside of homes. We ask the person to come out to meet them. So there's all sorts of little things like that, driving safety, safety kits, vehicle inspections, whether one or two people have to respond, alternative meeting places when the visit's deemed unsafe for any reason. And then we immediately add that call and information to a tracking spreadsheet so we can track where our staff are in real time to make sure we ensure their safety. And there's really two tracks: the hospital ER secure facility track, and then the home or residence track. Obviously, the home is the more unsafe option, but we wanted to make it available to everybody. And then, who should be referred to the AIME team? Right now, we can do adults over the age of 18. I really want to expand that to juveniles. So I will look at ways to be able to safely and appropriately do that in the future. But we allow people to call when they're intoxicated, whether or not they're willing to enter treatment, because we want them to understand you can call back as many times as you want. And whenever you're ready, we're here and we're ready to go and we'll come get you. They can have co-occurring mental health diagnoses. They can be inpatient, outpatient, emergency department, side of the road. They may need ongoing support. They may or may not be in need of MAT. So pretty much it's open to anybody that wants to call. Who cannot be referred, obviously the juveniles, patients being discharged with open IV lines, PICC lines, or peripheral. We can visit those patients if they're inpatient, but we can't take them, transport them anywhere with those open IV lines. We will see people that have histories of violent or sexual behavior, but they cannot be exhibiting those behaviors currently. And obviously people call and they're not willing to speak with a peer supporter as much as their families might want them to. If they're not willing, we can't force them to have a visit. So we do get those calls sometimes. And we have gotten calls from patients with active COVID and flu infections. So we cannot take those people either. There's also a slide included, it's 2 slides up, about why do we use peer recovery supporters. I'm sure most people on this call already know why, but I always include, particularly when I'm educating people that aren't in the healthcare system, that there are improved outcomes when peer recovery supporters are used. We try to make it very clear when we promote the program and when we talk with clients, families, and hospital staff that we are not the police, that it's free. You don't have to have health insurance to really ease their minds. And then on the final slide, I did include contact information. If you're interested, there is a 24/7 hotline. And then I can't think of a time when they did not answer the call. We've got phone trees so that calls don't get missed if someone else is on the line. And if you have program information, I provided you with my email and cell phone number. Please don't give the clients my cell phone number. I've made that mistake before, but have them call 513-620-RING. So I appreciate you letting me speak today. I'm excited about this program.
Great. Thanks so much, Lisa. And yeah, a lot of people in the chat were super excited about the program as well. So we think it's really great. So I know we're extremely ahead of schedule, so this will leave us some room for open discussion and some questions. We already have a few in the chat. So these are for the Talbert House. So Tiffany and Brad, for Talbert House, how short-term is your treatment? In other words, what's the average stay? I believe you said 12 days. And yeah, is it inpatient and outpatient?
So yes, so the average stay for clients is 12 days. For that would be all clients. For successful clients, the average stay is more along the lines of about 23 days. And with regard to referrals, we can generally get clients in same day.
And I'll just add to that, one of the, as you know, I mentioned earlier, some of the learnings that we had, I believe when we put pen to paper, we were thinking between 3 and 7 days would be the average length of stay. Some things that we didn't account for is the fact that many of these individuals coming in do not have a safe place to go when they leave. And so Tiffany and her team, along with some of the housing programs here in Hamilton County, have had to work pretty closely together to find that secure environment. All of us that are in the field know that if we just put them right back where they overdosed, the likelihood of success is really low. So yeah, the average length of stay, that's a huge impact on drawing that out a little bit more to secure that safety for them.
I guess in that vein too, with the housing, was that an easy connection to make when like with referring patients afterwards, or and are all housing authorities in Hamilton County on board with this?
So the connections with our clinical team and our peer recovery coaches, that has made it a little more seamless transition. Talbert House has a lot of resources with regard to housing, so that makes things much easier and seamless process also. But with regard to one other point I want to make that helps increase our success rate and also our average length of stay is that peer recovery coach piece. And that helps really speak to those clients who are considering going AMA, leaving against medical advice, and, you know, have the triggers, have the cravings, and they are able to speak with these individuals and help normalize the discomfort that they're going through in conjunction with comfort meds that we can provide through our nursing. So that also helps many of our clients weather that storm early on when they really are suffering, whether it's physically or emotionally.
Mm-hmm. Great, thanks. And then I believe this is related to Talbert House as well, but can any EMS or fire station from Hamilton County utilize the 24/7 option, or is it specific to Cincinnati EMS and fire?
So that was in conjunction with Chief Winston, who is over Cincinnati. However, we do have our referral number, which is area code 513-338-8738, that anybody can call. And because we do have that 24-hour intake, we can get individuals in.
Mm-hmm. Yeah, and we can send that the number and the information out afterwards too, with the slides and the recording. So thanks, Tiffany. And then one more question. So do you have an engagement center for both youth, or is it just for adults?
It is only for adults at this point in time.
Okay.
But we are co-ed.
Yeah. So, oh, go ahead. So I guess a question for all, what referral services do we have for the youth under the age of 18? If you all know.
Well, we do. I mean, as far as outpatient services, we will serve outpatient youth. And we do also have passages for girls, but that's a residential facility. Most of our referrals right now have been mental health, but we do serve drug and alcohol there as well.
Mhm.
And those referrals generally come from JFS. We will have some direct referrals from family. And so that's one option. It's limited. We only house up to about 12 girls at a time. And we are generally close to capacity there.
Mhm.
We use Lighthouse Youth Services a lot too, but we will assess juveniles and find an appropriate treatment center for them here. It kind of depends on the youth involved and what level of care they're going to need, but we do routinely do youth assessments at the council as well. But Lighthouse is amazing.
Yeah. Oh, that's great. And then, yeah, thank you for that. So also for Tiffany and Brad, you mentioned funding. Is your, do you take all types of insurance? If someone doesn't have insurance, how do you fund their care? And then also, I guess in general, how is it mostly billable hours that you receive your funding, or do you also get funding from grants as well?
So we are grant funded. We receive funds in part from the Hamilton County Mental Health and Recovery Services Board. We take Medicaid. And like I said, if they do not have insurance, then we will work with them to get them insured.
Yeah, and a little more detail on that. So we do receive state opioid response funding. The Hamilton County Board does provide funding through our treatment service levy that we have here in Hamilton County. And Tiffany's right. If an individual has Medicaid or private insurance, we will bill those delineated services out to those payer sources. So in general, if you're a Hamilton County resident, payment should not be an issue. And so now obviously things could change if the SOAR dollars aren't renewed or levy dollars aren't sufficient enough. Those would all be a challenge for us. But Tiffany's been working with our team to increase and help individuals get onto Medicaid, which allows us to extend those programs out further.
Yeah, that's great. And Lisa, I know you mentioned that too, in terms of sustainability for your program. You said you're grant funded as well. Is that correct?
Yes, I'm working with legislators to kind of improve billable to improve how we think about billing to particularly to Medicaid and the mental health board for crisis services, for people, when you can't complete that assessment right now, when it's all about reaching the individual where they're at and intervening, that in my opinion should be a funded service through health insurance, particularly because it may save their life ultimately. But as it stands right now, it appears that our grant will be renewed at least for the overnight. And state opioid response may be able to help with that too. We may change up with SOAR 3.0 kind of what services we intend to provide if we're able. But it certainly is a challenge. But I mean, ultimately, if you bring people into your treatment program, as the Addiction Services Council expands and hopefully is able to do that in the coming years, maybe that's something that you're just able to, streamline, but you pick them up, do the assessment and kind of roll it all into one. So that's kind of the idea going forward. But for right now, it's a dangerous game we play when we provide these services and they're not billable. So we really need to advocate at the state and federal level to keep the dollars coming for programs like these.
Yeah, and you mentioned gas prices and using the case manager's own cars or the peer recovery supporter's own cars. So that's a pretty big issue too. but I liked that. I think you all mentioned that the insurance is covered, or you worked with insurance to get them covered or something along those lines to make sure that they can drive their personal vehicles, which I didn't know. And then Randall, I believe did you have a question?
No, well, I wanted to chime in a little bit about about the insurance companies and funding. Up here at Public Health, Dayton and Montgomery County Addiction Services, we have a team of peer supporters as well that does outreach in the community. And when we come to a person who is just ambivalent to do treatment, but they're willing to engage in some peer services, we were grant funded, and 4 of our peer supporters grants, or 3 of our peer supporters grants lapsed. So we learned that we could bring somebody in for an assessment who is willing to do any no treatment, but willing to speak with a peer supporter. And as long as we did an assessment and documented that they denied, whatever level of care was recommended by a clinician, and were only interested in peer support, that we can bring them in and bill their Medicaid for peer support services only. So that's one of the ways that we have worked around losing grant dollars in order to keep people engaged until they're ready to commit to going to some sort of treatment service program. That's it.
That's great. So you bill for peer support services. That's really interesting.
Yes. Yes.
Okay.
Yeah, I know one of the challenges with those, and you probably know this, with the peer support, is getting them certified. And Tiffany, you can tell me if I'm wrong, or someone else. I believe now they have an online training, where in the past you had to wait for the classroom training. Even it could have been live and or live online, but now they have where there's more access to it. We had a number of people, and you have to be certified in order to bill Medicaid. So we've had peer specialists that do the service, but we couldn't bill. But it does appear that the state's loosening some of their requirements, or allowing more access to get people trained. So I think that's going to be a service area that's just going to continue to grow. And I don't know how many, Tiffany, do we have right now on staff for peer, but it's when you get a good peer specialist, they're worth their weight in gold.
Ohio Moss just recently opened up the e-license portal for peer recovery supporters as well. So the process of people obtaining the peer recovery support certification through Ohio Moss is much quicker than what it was, let's say, 6 months or a year ago, because there was a lot of issues going on where it was taking months for people to get that certification after they had completed all the proper training, or required training, excuse me. So they're beginning to loosen the reins a lot, so to speak. And then they're also, excuse me, sorry, that's my phone going off. They're also they got rid of the requirement to do the background check every single time they went in for their recertification as well. I'm not sure if everybody was aware of that or not.
We actually got a county grant to provide peer support training ourselves to Hamilton County residents for free, which was nice, but we were not permitted. If we were permitted to do Zoom, but we have, as far as I know, we were not permitted to record and do webinar trainings.
And I may be wrong, Lisa. I feel like I came across something. I was like, oh, that would be great. It would be more access, but.
Well, I think it's ridiculous, the hoops that they have to jump through. I mean, we do CDCA as well. And you can be a licensed chemical dependency counseling assistant and go through much less. There's no exam. There is for peer support. it's really been difficult to navigate that system. So we decided to do it ourselves because it's just easier that way, but it's still, asking people to take an entire week off of work to do a Zoom training is really difficult. And then they need help. There's online courses before the course that you have to complete 16 hours. Then they have to navigate the e-license portal, and we've actually taken it a step further with that grant, and we have been assisting people with sealing their criminal records because that's a lot of peer supporters have a criminal past that is difficult to overcome. And it's not that they won't approve their licensure, but it's just one more thing they have to do. And there's a sign at the corner of my street at White Castle that they're paying $18.50 for managers right now. And it's like, for what they're going to get, although it's rewarding, it's really a lot of hoops to jump through. So I'm glad to see they're changing some of it, but it's a lot for sure.
And then I saw this was shared in the chat, but I just so Hamilton County Public Health actually does work with Eastern Seals of Greater Cincinnati to run a peer support training program, which I think actually Addiction Service Councils and Talbert House both participate in because they do a paid internship. But we started that, and I know this is not totally on topic, but obviously peer support play a role in everything that we're doing. When we looked, it was, I think, almost facilitated trainings in Hamilton County maybe twice a year, which made it really inconvenient for a lot of individuals who couldn't make the trek to Montgomery County or Franklin County. And now Easter Seals is holding them fairly regularly for program participants. And I know they're working on expanding to open up the trainings to individuals who are not necessarily just a part of that training program, but just need the actual training. And they have their own master facilitator in-house who can hold trainings now, which is great. And that is great, Lisa. I didn't know that, to hear about the relaxing of the background checks for renewals, because I always found that baffling that as a nurse, I don't have to do a background check when I renew my license, but peer supporters were being held to this higher standard, which just created more barriers. So that's great to hear that they relax that.
That's that lovely stigma, right? And somebody asked about working with the Veteran Affairs. And that's something I just want to mention for me, that it's a challenge for me. It seems, and excuse me if I'm being forward, but it seems like the VA can be an impenetrable wall. And if there's any contacts or things that I can do, my mom's a VA nurse and I adore them, but she'll tell you herself, they are an impenetrable wall. And I know that the VA has their own treatment services that are exceptional. But some of this stuff, like if we can get, veterans and get them to the VA, for treatment, we'd love to be a part of that. So please reach out to me. You have my contact information.
And Lisa, I'll actually connect you with them because the VA, actually, we've worked with them to help them launch this, but they have a pretty robust harm reduction program in addition to the treatment program. I think their biggest problem, similar to a lot of nonprofit or government organizations, is they're really bad at marketing and sharing the services that they offer. So they actually have a great program actually that operates downtown separate from the hospital. I think that they probably need help connecting veterans, and as much as we want to get veterans to that program.
Thank you so much. I love that.
No, thank you, everyone. And then a quick question, Randall, I actually think you mentioned it regarding people who aren't ready to receive services. So for instance, if a family member sees one of their, is calling for on behalf of the family member, and it's not actually the patient, can you treat the patient even though they are not the one calling, or do they have to be fully willing to participate in your services?
So for us, if it's the family calling, we will try to assist the family in whatever way that we possibly can, whether it be fentanyl test strips, Narcan training, linkage to family resources that's available in the community and counseling. We try to emphasize what better way to show their loved one who is in need of services.
Yeah.
Role modeling, getting services for yourself. But no, if the consumer, we call them the consumers because they're not clients, because we have an outpatient program.
Mhm.
But our outreach consumers that we see, if they are not willing to engage with us in peer support services, then we just provide that service for free. It is not, so it was something at one point in time that was grant funded, but public health has fully bought into the idea of outreach services in the community. And there is continued work that I'm part of with the NASW Ohio chapter on really working around some different advocacy plans to try to get our Medicaids to
Mhm.
cover outreach services, because they used to back in the early 90s and 80s.
Mhm.
So that's just some additional stuff that's going on the back end to try to get these services covered. But if they're
Gotcha.
not willing to do peer support services, we can't go for it.
Yeah. Yeah, that goes for everyone too. Yeah, question for everyone.
I get a lot of calls from family members about Casey's Law. So
Yes.
I have spent a lot of time down at probate court figuring out how to navigate that system. I will say that it is, I don't know who created those rules. But someday I'm going to get a bill at the Ohio legislature that fixes some of those. But until then, we have been able to meet family members down at probate court and help them navigate the Casey's Law process. And we actually will attempt to call the client that's unwilling or shoot them a text or a message from our Facebook. And sometimes they do engage. But if anybody has any questions about the Casey's Law process and how to kind of get around some of the obstacles, we are here for that. And I would say we're slowly becoming Casey's Law experts. So you may get calls about that as well. And it is really tough.
With regard to the engagement center, our referral call process, we can start that with whether it is a nurse from the hospital, a family member. There are periods of time where we need to speak with the individual specifically and get some information. Because we are a voluntary program, it's much more beneficial if they have at least some minimal buy-in, because if it's just a family member bringing them in, dropping them off, unfortunately, they can turn right around and say, I don't want to stay. We have intensive case management and peer recovery coaches that try to help them process through that and to stay. But it is more challenging if it's just solely the family members or somebody else wanting to get them in, and the individual has no buy-in whatsoever.
That makes sense. Yeah, well, thank you all for that. Especially, yeah, I'm personally, yeah, I've just heard of Casey's Law too. And Lisa, after your law degree, maybe we can really get that bill into Ohio, like you mentioned. But yeah, so I don't believe we have any other questions at this point, unless, did anyone else have any other questions in the chat? Or anything else that our presenters would like to add? No? Let's see. Yes, the slides we're sending out the slides and the recording afterwards, as well as contact information. So be on the lookout for that. But with that, I just wanted to say thank you, everyone. And thank you to all of our wonderful presenters. We really appreciate your support and the great work that you're doing in Hamilton County and throughout Ohio. So we do have a survey that we'll follow up with afterwards, and that we'll send out with the recording as well. And again, we just want to say thank you so much, and we really appreciate it. All right. Have a great day, everyone. Thank you.
Melanie.
Thank you.
Thanks, everyone.